Okay, thank you so much, everyone, for joining us today for a very special edition of our Tea Talk, Endometriosis Awareness Month edition. We are excited today to have three Houston doctors with us to talk about endometriosis and to answer your questions. So, just a little housekeeping before we get started. The doctors are going to do a short presentation on endometriosis, and then we're going to open it up for a Q&A. If you have questions, you can direct those to Maria or to myself. I'm Allison. And we will ask those questions to our wonderful doctors. Today, we are joined by Dr. Xiaoming Guan, Dr. Tamisa Koythong, and Dr. Joseph Nassif, who are physicians at Texas Children's Hospital and affiliated with Baylor College of Medicine. Thank you so much for spending your day with us today and being willing to come on, answer questions, and to help us learn more about this disease that affects so many people in the Houston area and beyond. We're very lucky to have qualified professionals in Houston so that people don't have to travel as much as, some people in other cities and other states who are not fortunate enough to have doctors who know anything about endo. So it's great to have you all. Real quick, I'm going to do a brief introduction of our doctors, and then I will turn it over to them. Okay, today we have Dr. Xiaoming Guan, who is the Chief of Minimally Invasive Gynecologic Surgery at Texas Children's and is a professor in the Department of Obstetrics and Gynecology at Baylor College of Medicine. Dr. Guan earned his medical degree at Fujian College in China. He completed his obstetrics and gynecology residency at St. Joseph's Hospital, a Mount Sinai School of Medicine affiliated hospital in Paterson, New Jersey, followed by a fellowship in minimally invasive gynecological surgery at Baylor College of Medicine here in Houston. He brings extensive experience in treating complex and challenging cases of endometriosis, uterine fibroids, and pelvic masses. He is a leader in minimally invasive gynecological surgery and a pioneer in the use of NOTES techniques. He also serves on the advisory board for the Endometriosis Foundation of Houston. Thank you so much, Dr. Guan, for joining us today. Joining him, we have Dr. Tamisa Koythong, who is an assistant professor in the Division of Minimally Invasive Gynecologic Surgery within the Department of Obstetrics and Gynecology at Baylor College of Medicine. She completed her undergraduate studies at the University of Texas at Austin prior to obtaining her medical degree at the University of Texas Health Science Center at San Antonio. She moved back to her native home of Houston, where she completed her residency training in obstetrics and gynecology and fellowship training in minimally invasive gynecologic surgery at Baylor College of Medicine. During residency, she was the recipient of the AAGL Recognition of Excellence in Minimally Invasive Gynecology Award. Her experience and surgical training in the treatment of endometriosis has been under the direction of Dr. Xiaoming Guan. Lastly, joining us today, we have Dr. Joseph Nassif, who is an associate professor at Baylor College of Medicine and Texas Children's Hospital in the Minimally Invasive Gynecological Surgery Division. He specializes in OB-GYN from St. Joseph University in Beirut, Lebanon. Then he did a fellowship in minimally invasive gynecological surgery in the European Institute of Telesurgery. He has a diploma in medical education, an MBA in hospital management, a master's in cellular and clinical sciences. He's the author of many articles as well as journal, book, and chapters and scientific communications about these topics. He has been a guest speaker in many international meetings and reviewer in scientific journals. His main interests are minimally invasive gynecological surgery, endometriosis, Müllerian malformation, and pelvic pain. Thank you so much, Doctors Koythong, Nassif, and Guan, for joining us today. Dr. Guan, I would love to hand it over to you and your team.
Thank you. Thank you, Alison. Thank you for Endometrial Foundation of Houston. I still remember this couple of years ago, we start with I have trip to the Dallas, and we met our Houston endometriosis, then we have our own T-Talk. So that time we're talking about, we want to fight endometriosis together in Houston. So actually we talked a couple minutes ago, our main goal and our team here, minimal invasive division at Baylor College of Medicine, our goal is going to fight endometriosis in Houston. We, as Alison will already talk about, we want our Houston patient, our lovely Houston patient don't need to travel to other states, other expertise to get a treatment. I do believe our treatment method and our incision surgery equal and to the national. And I'm so lucky, and today we have two faculty join us. So as you talk about, these two faculty we hire for, especially for endometriosis surgery. So they are competent for the surgery, and they do the same method, incisional surgery for endometriosis. Welcome everyone. If in the future looking for treatment, you're looking for Dr. Koythong and Dr. Nassif too. And since they are new joining, and we have T-Talk format we discussed before, and normally we give a little bit lecture about kind of everyone more concerning questions. So then we go to have open discussion. This year I'm going to do a little bit talk. Then we open the most time to discussion because I have more faculty join in. So you are going to hear a different opinion or same opinion. So that's great for your choice and more options. So welcome everyone to join us, and thank you for your time. And again, thanks Alison and everyone, and the Endometriosis Foundation of Houston. So glad to work with them. I'm in advisor board, and so happy to join, to able to work with, and we're going to fight endometriosis together, and we're going to win. So I'm going to share my slides. So I don't know. You can see the, okay. So I like the Endometriosis Foundation of these pictures have both endometriosis color and pink stand for our female patients. So black suffer for, we really suffer for this disease, and this black flower stands for we're going to win. At the end, we're going to fight together, and we're going to win this endometriosis battles. So, and recently, last year, we talked about a little bit endometriosis and more related to pain. I initially started this endometriosis program more related to pain, but recently, I find out more and more patients asking about endometriosis surgery and basic fertility issues. And more infertility, basically reproductive endocrinologists refer a lot of patients for us to do the surgery. So then a lot of questions coming out. When to do the surgery? Really surgery help? Really we need to do the surgery, and any IVF treatment worsening the endometriosis or cause any disaster, anything happens. So I'm going to give some kind of discussions here, basically no consensus here for this one. So I still put out this picture for endometriosis in case a new one, new here, no endometriosis. Endometriosis basics is a definition is endometrial tissue in the uterine lining outside of uterus. include in the uterine wall. Then it causes the basically adenomyosis. In the ovary, we call it endometrioma anywhere. So basically, all the organ we have to find endometriosis. There's one time I was a couple of years, I went for fellowship interview, now a couple of years, already more than 10 years ago. So one of endometriosis pioneer, senior manager from Atlanta, he interviewed us. He said, okay, if anyone can answer the question, which organ did not have report endometriosis, you're going to direct go to be his fellow. So we know what answer this question, but he gave us the answers. So basically it's the spleen, but actually now have the case report in the spleen too. So basically endometriosis can go to any organs, anywhere. So that's why anything related to periods, pain and the mass, you can suspicion for endometriosis. So endometriosis surgical related concerns, there's two issues. One is the fertility related issues and the recurrent pain. So recurrent pain, we're going to for open discussion. About the fertility related issues, there's concerning infertility. However, there's no clear consensus about surgical treatment. What's the percentage of, and there's a question about a lot of patients, 30 to 50% of infertile female have endometriosis. Sometimes endometriosis can grow inside your ovary. So basically it's endometrioma. This is more concerning, right? You have something growing into one of making your eggs. So there's endometriosis there growing, forming a mass. So what this can do, so always this is a concern. So then I pull out this like a reproductive facts.org. Basically, ASIM gave the fertility organization give some, how can endometriosis influence fertility? And I give this kind of lot of, this is basically the kind of risk, right? Possible. One is a distorted anatomy of pelvis, adhesions, scarred fallopian tubes, inflammation of pelvic structures, and the immune system change and change hormonal environment in eggs, impair implantation of pregnancy, and the egg quality change. And this talk a little bit more related to like kind of academic things. I was surprised how much information and kind of our patients know. They came to my office. They sometimes better than some of physicians. Basically, they know endometriosis better than anyone else. That's why I give this all kind of terminology here. I'm not worried. So I worry about you guys don't know. So endometriosis is the leading culprit of infertility of women, right? That's the reason drive many people to pursue IVF. So then question come up, IVF retrieval make endometriosis progress? So that's our literature. So that's one literature, 2011, I pull out. This literature thought IVF does not expose women to consistent risk of endometriosis related symptoms progress. So this means what not affect. However, there's many arguments and discussion about this paper. So they use the ultrasound technique. Another one is ultrasound in some place is not a good diagnosis for endometriosis. If endometriosis is not like a deep infiltrated endometriosis or endometrioma, sometimes ultrasound cannot diagnose this. So that's why this paper, many people have argument about if this is correct, you can put it there. So then there's a couple of physicians about endometriosis. So this is all from reproductive endocrinologists. This Dr. Chen from New York, I think, talking about endometrioma can take over the architecture of ovary. The sooner women seeking help, the better. So I like the word of architecture. Basically, it really changed the architecture. That's why it caused a problem. Then the other physician, Dr. Thomas Singer. So the patient with endometriosis typically need double the number of cycles to achieve viable pregnancy through IVF. So it means what? Endometriosis do a lot of things on the egg and the ovaries. So this is a paper from Dr. Chad Miller. Actually, I reviewed this paper, so that's why I remember I pull out this one. So she talking about changing the endometriosis on the ovary, which means it's endometrioma. What we should do, this algorithm give us the, I just put it there, you see. So basic is all talking about egg retrieval, embryo, optional. So I pull out this algorithm to try to convince, if possible, I suggested my patient to do the egg retrieval if have endometriosis surgery. So if I have endometriosis surgery one time, normally second time, I strongly suggestion my patient go to do the egg retrieval for egg preservation. So we have like couple examples. There's many patients come to me. At the beginning we do the surgery, right? So have endometrioma. One of my patients came to me, first surgery, she had a 10 centimeter endometrioma. I did the surgery. So I removed endometrioma. After endometrioma, so I suggest patient go to get the egg retrieval. In some reason, he did go to see the REI physician. However, in some reason, because of work, everything, she did not finish it. But she ended up severe pain again. Then we find out less after 3 years, she had endometrioma. This time endometrioma 5 centimeters. I suggest her to go to the egg retrieval first, then come back to me. So to do the surgery, but because severe pain, she said, I just want to taking care of pain first. I went in to do the surgery. So obviously, so this patient already have one ovary be taken out before my surgery. So this is talking about only one ovary left. So I did the second surgery. Then she tried to get pregnant, went to REI. They never, you know, that AMH, anti-Mullerian hormones. We always, REI, they check it. So her AMH lower than 0.5. So, you know, if your AMH higher than 1.5, normally it's pretty good shape. So this is just kind of one of story about why we do multiple surgery on the ovary can cause the potential harm to your egg. So that's why the suggestion you should consider to do egg retrieval at between even if you before the endometriosis surgery, endometrioma surgery, I even recommendation patient to do the egg retrieval first, even before first surgery, not the second surgery anymore. We're just more concerned about get them. So in the same time, if you have both ovary have endometrioma involved, it's worse than one ovary involved. So what's the risk of egg retrieval? I just pulled out from the same website. So, and they did not mention anything about the endometriosis. So they said mild to moderate pelvic pain, and in most cases, the pain disappear 1 or 2 days. This is sometimes related to overstimulation, injury to organs. So if you search through internet, they not talk about endometriosis. However, so I pull out one of literature review. So ovarian stimulation and endometriosis progress or recurrence. So first, they come up with 5 conclusions. First one, IVF not worsening endometriosis related pain symptoms. Not enough literature support. I think so because I searched the literature again. IVF does not increase risk of endometriosis recurrence. It's not true or not true. Need more literature supports. An impact of ovarian endometriosis, if present at all, is mild. And IUI increased risk endometriosis recurrence. So why? Because of high dose estrogens. And deep infiltrated endometriosis might progress with ovarian stimulation, very low quality evidence. So this is kind of a situation now, or this regarding. Okay. So I just want to give some story about egg retrieval patients after egg retrieval, how endometriosis happens. So one patient, 37, we're not giving name. If it's you here, just thank you for for here. We not release any name and information. We change a little bit, but stories exactly, but change some, try to maintain a HIPAA. So 37-year-old with the history of endometriosis, pelvic pain, 5 years. This is the basics. She had endometriosis surgery before me. So she had pain-free after endometriosis surgery. That time is stage 3. 5 years later, she had egg retrieval. So end up with only one embryo. After 1 month egg retrieval, she came to my office. So basically asked me talking about, so she had severe pain. Obviously, we check her. We know it's endometriosis coming back. I ordered MRI. So MRI find out have endometriosis on the urethra, have endometriosis on the bowel. So, and the uterus enlarged a lot with the adenomyosis. So then I pull out her previous history, right? She did not have any imaging study in this after surgery within these 5 years. So we don't know its progress. However, she did not have any pain before egg retrieval. I assume this is possible because of at least getting worse, right? So we end up with, we have to remove her uterus, and she had have to remove her bowel, have to remove both urethral nodule to the implantation. So after surgery, her pain-free again. That's good news. Another good news, she had a baby with this one embryo. So you guys know how she got a baby, and she sent a picture to me, and so adorable baby. This is the good result of she had egg retrieval. But however, this is highly suspicious. Actually, basically, the stimulation can cause the. She did not do the transfer. We just after stimulation we did the surgery. Then the other patient have a 38-year with history of endometriosis IVF process from another country. So she came to Houston. So her family in Houston. So she came to Houston. So I did the MRI, and she had a typical sciatic nerve pain. So we did the MRI with the nerve MRI basically. Then we find out have an endometriosis nodule close to the sciatic nerve, like maybe 2-3 millimeter. And the patient also have left kidney failure. At this point, always the good thing is we have a multiple disciplinary team here. So everyone know we have urologists, we have a colorectal surgeon, we have thoracic surgeon, and liver surgeon. We have one patient now, we need a liver surgeon to involve too. So basically, we went in to do the surgery, we removed the urology, removed the kidney, and removed the left ureter. And I removed the endometriosis nodule from her, basically close to sciatic nerve. We have to dissect the nerve, and remove the endometriosis and nodule. And her pain is much released, but still have some residual pain. But for on the patient, because we don't know the history of really what they do in other countries, so patient adamant that all her symptoms getting much worse right after IVF, egg retrieval. So another patient, 35-year endometriosis, personally after egg retrieval again. So we did the surgery. Basically, she had endometrioma. We do the endometrioma size increase and pain getting worse. I went in to do the surgery and found out she had the tubal ovarian abscess in the same left side. So we have to stop the surgery because she had the bowel involved too. So we stopped the surgery. We after 3 months and she come back. We did the surgery, remove her left ovary and tube, and she now is doing the IVF. And this is a story about endometriosis and egg retrieval. However, we just don't want to scare everyone. So this is not a way. So the disease should not pull off the basic is by the endometriosis horror story of IVF, right? Instead, my suggestion, you should be aware. You should aware not all IVF, not egg retrieval causing the problem, but egg retrieval potential have risk with the high dose estrogen and causing your worse. And you should seeking the physician, be like IEI physician experienced and endometriosis do the IVF. Maybe they can adjust the hormonal level and hormonal doses to help you with get pregnant. And in the same time, you're not going to get worse. And otherwise, you consult with endometriosis surgeon. So we give us some suggestions. Normally, we can convince and see. And also, if we have a kind of already have very severe disease on the ureter or on the bowel, at this point, you maybe need to balance. You should do the surgery first or do the egg retrieval first. So how about transfer? So endometriosis and transfer, I search literature. So this is one paper published from the effect of endometriosis on implantation from Yale University. So in this, they conclude that, so in patients with endometriosis, implantation rate is low. And so they consider abnormal implantation, which may be secondary to the endometrial dysfunction or embryo toxic environment. I highlight this one. So how I talk to patient about that, I think about like this picture, right? Baby sleep in womb. So basically, that's the bed for the fetus. So if you have a embryo toxic environment, so baby not sleeping there well. So that's why increased risk for the preterm labor, miscarriage, everything. So what we do, and then surgery can solve the problem. So I search the literature again. So let's a review for that. The effect of surgery for endometriosis in IVF embryo transfer. And they said, so even after surgical removal of endometriosis, IVF egg transfer results remain worsening in control group. This control group is normal patient. However, no comparison data of pregnancy rate before and after surgery with egg retrieval. It means, okay, you do the egg retrieval without surgery, and with the egg retrieval with the surgery. I think we need this kind of research to confirm really surgery help, not compared to normal patient. Obviously, you already have endometriosis, you do the surgery, you definitely cannot be better than the normal patient. So, and this is the one, the paper I'm talking about. So if IVF fail, surgery should be considered. So we have many patients coming back. One patient from Washington, DC. She has 6 high quality embryo. She tried to transfer 6 times, failed. So at this point, I think then her physician said, oh, you don't need surgery. You should continue to do IVF. You know how much cost IVF and everything. I disagree with that physician. I think at a certain point, you have to consider why it keep fail. You need to looking for other sources, not from basics from the social issues, financials, and everyone is stressed. This IVF cycle, you went through 6 times, so obviously we're going to do. And this patient, we did not do the surgery yet. We're going to. Anyway, I checked her in highly suspicious endometriosis. We're going to do endometriosis, then go back to IVF. So that's the point. I think this is the article give a good suggestion. After IVF failure, surgery should be considered. However, in this article, they did not mention how many cycles fail. I don't know too. So that's why you have to use your own judgment now. And success egg transfer after surgery. Basically, my philosophy, if anyone here is my patient, I will tell them, okay, we're making a better environment for the baby. So that's why baby can carry on and sleep better. So we have one patient. So basically, one of my fellow told me, so basically she posted on the Nancy's note. So I did not do the screenshot, but I know her. So she had a 5 transfer and failure transfers. So she came to me for she still had 1 embryo left. So she had endometriosis stage 3. So that time we just said, we're going to do the surgery. She said, this is my last shot. If fail, I'm not going to try to pursuing for pregnant anymore. I went in to do the surgery. Then she got a baby after IVF successful. And she came to my office after a couple of months, and she brought the baby, and we took the picture together. She was so happy. I'm very proud of too. So we able to make it. And this is because of surgery or not, we don't know. But we did have many patients after surgery successful. Let's many patients. Let's another example. One patient who not do egg transfer. She just said, I just want to get pregnant naturally. So I did the surgery. Every time I do the surgery, she got pregnant. After 2 surgery, she got 2 babies. Then she have adenomyosis. We did a hysterectomy. So this is kind of story around a lot of this kind of story. But however, we need more evidence base to support. So in my practice, so Dr. Koythong and Dr. Nassif will give you their own opinions. So suggestion, I normally suggest egg preservation first. If you have endometriosis, especially ovarian endometriosis. Ovarian endometriosis include endometrioma, or you have surgery on endometriosis on the ovary. That's my suggestion, especially in younger age. So I normally suggest them you should consider it. This is no evidence based, but however, now more and more people suggest, actually endometriosis specialists suggest them to do it. And a lot of patients ask me, what's the best chance of getting pregnancy? So that's one of literature recently come out from Italy. So basically, actually before this literature, we always tell patients, you're going to get the pregnancy, the best chance is within 1 year of surgery. So this literature support, they compare 1 year within the surgery and 1 year after surgery. Within the surgery, higher chance to get pregnant. And the surgery should be considered 1 or 2 months after egg retrieval. That's my own opinion. Because when you do egg retrieval, you get all the tissue swollen. Basically, a lot of water inside. So we want this water to cool down, so then we can do the surgery. And normally we suggest patients to do the egg retrieval, get enough high quality eggs, then we do the surgery. So this kind of way we consider can reduce your chance of surgery. If we do the surgery before egg retrieval, then you have egg retrieval, you potential have chance coming back for another surgery, because egg retrieval, high dose estrogen can produce, maybe stimulator. We have many patients, even no evidence support, but I have many patients come back because of that. So that's why we now normally prefer to do egg retrieval do the surgery after egg retrieval. And for IVF patient with the pain, I normally suggest patient do the egg retrieval first, then do the surgery 1 to 2 months after egg retrieval. Then we do the 3 months after surgery. We normally recommend patient to do the egg transfer if possible. However, this is a certain situation. Like if patient on the extreme pain, we normally said, okay, you cannot tolerate the pain, you cannot tolerate egg retrieval. We go ahead to do the surgery, or sometimes the IVF physician could not reach the ovary, they could not do the egg retrieval. At this point, we have no choice. We do the surgery first, then go to IVF. This always kind of special circumstance. I just bring out this kind of recurrent, like a pinpoint about this kind of how might consider if you have surgery, after surgery, you have recurrent or relapse pain after surgery. So we're going to discuss about like you guys have questions. I normally tell patients the pain from multiple compartments, not only from endometriosis. So sometimes inadequate surgical treatment, which means you do the surgery. Sometimes the patient do the ablation, or people do the ablation, or some patient come to me and say, okay, my physician said I have endometriosis. I remove some, and some left there because it's okay. So this kind of inadequate surgery, right? Incomplete surgery. So it means what that means. So in the surgery, if you have pelvic congestion syndrome, you did not address that, or you have adenomyosis. So adenomyosis, but you want to get pregnant. So adenomyosis, we cannot address this problem. So that's why you still have pain. Then your pain is maybe from the adenomyosis, from the pelvic congestion syndrome. Then non-endometriosis pain, I normally related to sometimes pelvic floor muscle pain, everything post-op. I normally after 3 months, I suggest patient to see the PT if I find out she had a pelvic floor muscle pain. So then the other one is after a couple of months, endometriosis can come back. So endometriosis recurrent rates, everyone quote different. So my quote is around 30% if you keep everything there. So in normally 4 to 5 years. So if in that time window, you possible need to consider have endometriosis coming back. Then the other question is pelvic adhesions. And pelvic adhesions definitely causing the pain. So this is already myself proved with so many patients. We went in and she had pelvic adhesions from previous surgery, my own surgery, obviously. And we do the endometriosis resection, again, the same location, and with anything suspicious, remove it. However, did not report endometriosis. And we lysis adhesions, less times adhesion, we lysis adhesions, then patients coming back is no pain. So that's why adhesion definitely causing the pain. However, about the adhesion barrier, there's a lot of controversy. We can discuss about, I know a lot of patients come up with the kind of piece of paper, say, oh, can you do this, can you do that? That's great, wonderful. Actually, I looking into after you present this to me. And thanks for that. So the resource. So Endometriosis Foundation of Houston, our own organization, and support our Houston group and our Houston, and also all our faculty will join there and support the Endometriosis Foundation of Houston. Obviously, there's other physicians in Houston, they can join in too. And this is a resource for us. This is wonderful. I saw they put out a lot of informations, tips, and all this quote, and from for the education. Then the other one is Nancy's note, and that's a good resource. And so far, I know this too. So maybe there's many of them. But in Houston, I think Endometriosis Foundation of Houston is a good source because first you can discuss with the patient from your own organization. So in local in Houston. So sometimes we have patients before, they change the surgical day in a group. They told me, we are going to find someone change my surgical day. You see how beautiful is this? You in this foundation. And again, I'm so lucky to have two wonderful faculty with me. I try to introduce them again. And you guys definitely can be comfortable and looking for one of them to do the surgery like the same as me. And this is, I pull up from the internet anyway. For myself, Dr. Koythong and Dr. Nassif. So I need to appreciate, this is Allison's. This is for last year's still there. So I really appreciate all the patients support me for so many years and my team. So this is a picture for, I think it's for last 2 years. So thank you all. This is for the support.
Thank you so much, Dr. Guan. I just celebrated my 2-year anniversary of surgery with you. I had surgery with Dr. Guan February of 2020, right before everything shut down because of COVID. And I'm happy to say that I am pain-free. And, you know, I hope that everyone can have such a positive outcome between that surgery and doing tons of physical therapy, which Dr. Guan referred me to. I'm living a significantly better life thanks to finding the right treatment. So Drs. Koythong, Dr. Nassif, do you have anything that you want to say before we open it up to Q&A?
Tamisa, would you like to stop before me, or I have just like some small suggestions or addition, and definitely I agree with Dr. Guan with what he said. The problem when you go to infertility and endometriosis, I think that it depends if you are seeing an REI doctor and if you are seeing a surgeon. So it's why it depends. Sometimes with the guidelines that we have, the last guidelines that we have on endometriosis is from the ASHRI, from the European Society, which says that you can do surgery before IVF and you can do IVF before surgery. So you see, I totally agree with Dr. Guan. There is no clear recommendation, but from our experience, we know more and more, and from many publications, that the existence of endometrioma per se is going to affect the ovary. So just because you have an endometrioma in the ovary, you are going to get a lower ovarian reserve, and this is going to be with time. Also, sometimes, as Dr. Guan said, the surgery might decrease a little bit the reserve from the ovary after cystectomy, but we have many publications, at least 3 or 4, that show this reserve is going to go up with time after 6 to 8 months from surgery. It's why, as he said, the first year will be a good like timing to get the pregnancy, whether spontaneously or with IVF. And what was found recently, that the inflammation is not the problem with the ovary. It's more the deposit of iron inside the endometrioma. So whenever we have like iron deposit, they think it is toxic for the follicles around the endometrioma. It's why if you speak with an REI specialist, he will tell you they will never like pick up the oocytes when they stimulate them from around the endometrioma. They prefer to go a little bit away from it so they can get a better quality, because they expect to have a lower quality embryos just next to the endometriomas, because mainly about this iron toxicity. And here the surgery will play a role to remove, as Dr. Guan said, this toxicity from the ovary, but also especially if the patient has pain with her infertility. So here there's a big role for surgery, but also we can like improve the accessibility to the oocytes when we remove endometriomas of like 5-6 centimeters. So the REI people can be like at more ease to do their procedures. And this is why we in general do surgery on top of what Dr. Guan said about the estrogen that can definitely affect and stimulate the growth of endometriosis after surgery.
Tamisa.
I was just going to say, I don't have too much to add. As you alluded to before, my fellowship and my surgical training with endometriosis was directly with Dr. Guan. So you and the members of the Houston Endometriosis Foundation will see that my philosophy basically mirrors Dr. Guan's.
Yeah. Yeah, that makes sense. Do y'all have specific fertility doctors who you work with, who you frequently refer to? That's such a big question that we get in the Houston group all the time, is who do I see? Like, where can I go for this? Who knows what they're even doing when it comes to endo patients?
Go ahead.
So, so there are several infertility practices within Houston, one of which is located in Baylor. So we work with them, I would say, most closely, and we are able to access most of their records. So that makes kind of following plans and treatment plans and things like that more easy. But there are still 2 very large private practice groups within the greater Houston area, and that would be CCRM and Aspire HFI Fertility. And I know of people, close friends and patients who have gone with their practices and who have had ideal outcomes as well.
Yeah, so the same. So we normally refer to our, as Tamisa, echo Tamisa, right? So because of, basically if do the IVF in our place, normally our physician communicate with me, with my child. So like Dr. Zaretsky always say, okay, I did it. Dr. Guan, your patient do not have the egg, so do not have this. So I got the information through that. But however, there's, as I agree with Tamisa, there's many endometriosis. So basically, it's the endometriosis IVF center outside. There's I also refer to Dr. Kovandi, who was faculty when I was fellow. He trained me, so he's great physician. So that's why I refer patient to him too.
Mm-hmm. Great.
Yeah, mainly I work closely with the RI specialist in Baylor and TCH, so we refer them because it's easy to communicate with, as Dr. Guan said, and it's easy. Sometimes we like discuss cases before speaking with patients about the best option for them, and definitely when it's possible, we can get like even a specialist in endometriosis and FRI if we have, for example, you see some REI specialists, they publish more in endometriosis, or they have like they are more keen to take patients who have endometriosis. So it's, if we find something or some patients and some doctors like this, it's always better to go to them.
Gotcha. Dr. Nassif, earlier you mentioned this, the fertility struggle of, are they seeing an REI? Are they seeing a fertility surgeon? For patients who are working with one of you three doctors, is it preferable that they see someone who is more REI focused, since y'all, could take care of the surgical piece?
Yeah. So the way with the way we do it in general, if a patient comes to us with infertility, there is always a place for surgery on her, especially if she has pain. So in general, patients with endometriosis, they have either pain alone, either infertility alone, either pain and infertility together. So there are like three groups of patients when they come to you. That's why you have always to ask, do you have a plan to get a baby soon or not? Or are you trying to get a baby and you're not able to do it? So if they are like from the group of pain, in general, the surgery is not like to be discussed. If they tried previous treatment, it's not working like yourself. So surgery is indicated. If they're coming for infertility alone, in this situation, we have to discuss with the patient and if possible with the REI. So we can always like put the REI with us on board, and then we can see. But if they have both, so they have in general to go for a surgery again. So you see, like it's in 2/3 of the cases, they will end up in surgery, and in 1/3 we can always discuss with the REI. We can send them, and then we can decide. But always you have to speak with the patient like openly about all the options, what we know and what we don't know about the results of surgery and the results of IVF before getting into surgery. But if you see like all the new publications, especially for stage 1 and 2 endometriosis, there is a place for surgery. For stage 3 and 4, sometimes they say surgery before, sometimes IVF before. But as Dr. Guan said in the beginning, there is always, if we have like some IVF fail, it's always better to go for surgery, even if the endometriosis is in the bowel, is in the bladder, not in ovaries. So they can also affect fertility by inflammation, by sperm motility, by adhesions, by fibrosis, by many other means.
Great. Yeah, so I think that's really important to realize that, if you're struggling with fertility, Dr. Nassif just said, it doesn't just have to be on the ovary to create problems with fertility. You can have endometriosis elsewhere and it still impact your ability to conceive. And that's really important, because I think a lot of times we just focus on the ovary, we just focus on the uterus as these organs that are like the only thing that matter for fertility. And endometriosis can really have a far-reaching impact no matter where it is. Great. We have someone asking for clarification. Dr. Guan, can you say who it was that you recommended for IVF again?
So we recommend to Baylor's faculty.
Mm-hmm.
And otherwise, Dr. Kovanchi.
Kovanchi.
Yeah.
Okay.
Do you want that spelled at all?
That would be great. Yeah, I think they were wanting it to be spelled.
His last name is Kovanci, and his first name I think is Ertug, right?
Yeah. Ertug.
Or Ertug.
Awesome. Yeah, that'll be a really helpful recommendation for people to have. Let's see. Trying to keep up with all the questions that are coming in. This is great. Let me see. Okay, so when we've talked a lot about endometriosis and its impact on fertility. What about adenomyosis? Obviously, the only cure for adeno is a hysterectomy, but pre-hysterectomy, what is the implications for fertility? And what can be done, if anything, to improve a person's ability to conceive with adenomyosis?
Okay, two of you go first.
So for me personally, I think adenomyosis is a lot more difficult than endometriosis, because with endometriosis, to me, there's a clear surgical approach in eradicating the disease. Whereas with adenomyosis, it becomes a little bit more difficult because in a patient who desires to maintain their fertility, to me, is not really feasible to go and cut into the uterus. These lesions are very difficult to appreciate surgically. It's really a histopathological diagnosis. And really, in terms of effect on fertility, I am not really sure about any clear data about its impact on fertility, but I can imagine any kind of personal impact on the patient with bleeding and or pain would interfere with their desire for intercourse, or perhaps low libido, and kind of affect their ability to conceive in that way. In terms of medical management of adenomyosis, I really see it as fleeting and temporary. Hopefully, with hormonal therapy, like with endometriosis, you can achieve some alleviation of symptoms, but really the disease can still progress despite that. Unfortunately, and hysterectomy may be the most curative when the patient is ready to pursue that.
Right. I know that that's such a difficult decision for patients to have to make. And a lot of times they feel like they're sort of going into surgery blind sometimes. Like, will we know before surgery whether my uterus looks like it needs to go? How does imaging play a role in the ability to sort of suspect adenomyosis? Can it, give someone a high degree of certainty about the disease, or is it sort of just like, you just have to kind of go by symptoms?
It's similar to endometriosis, so the same imaging modalities that you can use to screen for deep infiltrating endometriosis with an MRI or an ultrasound can still be used in adenomyosis. But if the disease shows up on ultrasound or MRI, I tend to see it higher stage, so more global adenomyosis affecting the uterus. So it doesn't really necessarily, rule out very, very small pinpoint lesions of adenomyosis that may be very, very small that could still be contributing to their symptoms. So unfortunately, it's extremely similar to endometriosis in that regard. But the surgical management of adeno that doesn't include hysterectomy is much more difficult.
Mm-hmm. Right. Okay. We have people asking.
So I add on some of a failure story about adenomyosis treatment. I don't know Dr. Nassif doing that. Before a couple of years ago, I went to conference. A lot of people do the metroplasty, basically resection of adenomyosis. I done a couple of cases. It's temporary release the pain, not fertility issues. Release the pain, however, is coming back right away. So then an easy forming a lot of dense adhesion between the bowel and uterus. That's why after I maybe tried like 5-6 cases. So because of when I went to conference, they said they do open case, they remove it, they can release, but almost everyone have recurrence. But if this patient for the fertility, but if you cut it too much, a potential problem. I don't know, Dr. Nassif have this kind of experience.
Yeah, so thank you, Dr. Guan. Definitely, adenomyosis is like the cousin of endometriosis. It's not like the sister. Now we know more. It's not the sister because we have like some different pathophysiology, but we can say it's a cousin, and sometimes these cousins, they come together. So for adenomyosis, as we said before, medical treatment is sometimes working, like IUD with hormones or hormone treatment, as Tamisha said. But the problem, if you give it and then the patient can be pregnant. So if they're coming for you for an adenomyosis and they want to get pregnant, giving like a medical treatment for them to decrease their pain or their bleeding sometimes won't work for pregnancy, because whatever you give is like, in a way, it's a birth control. So the option between what Tamisha said, like to have a hysterectomy, which is, now we know it very well, is the final and the best treatment for adenomyosis, and between like giving a hormonal treatment, was like these half solutions that Dr. Guan said. Well, we did some adenomyomectomies or some like bivalving of the uterus, where we think that the majority of adenomyosis is there. But as Dr. Guan said, I did maybe also less than you, maybe 2-3 cases, and we stopped because technically is like challenging, and the recurrence rate is very high and very quick. So in general, I say either like medical treatment or hysterectomy. I don't do this anymore.
Another one is about the diagnosis. A lot of patients come up with since we're talking about diagnosis. So thanks, Dr. Nassif's comment. So basically diagnosis, I was trying to do the biopsy when I just started doing that. I used a needle biopsy. However, caused the bleeding and did not find anything. And then I do the hysterectomy and find out I have adenomyosis, but my biopsy not work. So that's why I abandoned. About the endometriosis, the MRI or ultrasound. So it's not basically, if I told everyone, I said, if you MRI show adenomyosis, pretty sure you have adenomyosis. However, MRI did not show, you maybe still have. I don't know, Dr. Nassif and Tamisa agree or not.
I agree with that. And then another thing I'd add with Dr. Guan alluded to before in terms of surgery making the disease worse. So as a fellow, we actually operate on a patient with adenomyosis and fibroids, and we attempted to remove her adenomyoma, but had to abort the surgery because the adenomyoma was too large and it would put her at risk for hysterectomy, which she actually did not want. She came to see me a year later when I was in practice for bleeding and was ready to move forward with hysterectomy. When I got into her abdomen, she had very, very severe adhesions and new endometriosis that wasn't present a year before. So I think, because the tissue causing the adenomyosis is very similar to endometriosis, we might have inadvertently spread it into her pelvis, causing endometriosis, if that makes sense. So it made for a much more difficult surgery, and that surgery took 8 hours. So.
Oh, wow. Yeah, so it's definitely a complication that, you don't want to have happen as a patient. So thinking about adenomyosis, well, one, and then, when you go in and attempt to remove the adenomyosis, that can also create issues if a person does manage to conceive and carry to term with, can the uterus withstand labor? And having to revert to C-section as well, correct?
Yes.
Yeah. Okay. A question. Sorry, I'm trying to make sure I get to all of your questions. There are a lot coming in. We would love to be able to open it up and have you ask, but we've had some issues with trolls abusing the space, so we want to keep it really safe for you all. So let me just peek. Okay, and then what are y'all's thoughts? I know we're getting a lot of questions about adenomyosis, and it's Endometriosis Awareness Month, but I think that's an area where people know even less than they do about endo. What are your thoughts on like presacral neurectomies for managing the pain associated with it? Because it's one of those things that like you see some doctors do it, but then you also see a lot of doctors who don't do it. Do the three of you have an opinion on a PSN?
So I do not do that because I've never been exposed to the procedure. I'll let Dr. Guan and Dr. Nassif speak on their experience with it.
So when I was training during my fellowship, I maybe did one with my mentor. So after graduate, I did a neurectomy for maybe 5-6 cases. So however, So then I went to meetings, conference. I asked other expertise. Most of expertise disagrees. Pre-sacral neurectomy help with the pain, even so. But they do agree. Actually, possible help with the central pain. However, the side effect about basically you do the surgery, you can cause the bladder dysfunction, sometimes bowel dysfunction. So that's why after the procedure, since I do the surgery, I feel it's not helping patient too much. So then there's a couple patients come to me. Initially, some other physician want to do a pre-sacral neurectomy. We end up with dural endometriosis only, and patient pain was much improved. No need to do the pre-sacral neurectomy. This more convinced me. About evidence base, that's also controversial too. Some evidence, most evidence support pre-sacral neurectomy help with the central pain. Central pain sometimes is maybe adenomyosis, everything, but not with the lateral pain, left side pain, right side pain. So that's why pre-sacral neurectomy, my personal suspicion is really treatment for endometriosis or central pain for other things. Just any central pain maybe can help because you have nerve drive there, right? Surprise there. So if you cut it off, obviously the pain is gone. Maybe not necessary for endometriosis. So that's why I think maybe we should feel different if you do the sacral neurectomy. You tell you what I just do the for endometriosis pain, maybe not work because if endometriosis pain can be other locations, it's not work. Maybe central pain for other mass effect or anything maybe works, but you need to consider that you need to realize, be aware their potential side effect on this pre-sacral neurectomy and permanent. And there's a group of people called neuropelvics. They very upset if you do the pre-sacral neurectomy. They try to preserve all the nerve during the surgery for endometriosis, not doing the pre-sacral neurectomy. That's why, and my personal, I go with the preserved nerve. This is my own opinion.
Mm-hmm. Great.
Nassif, you can give.
Yeah, as a general like guideline or recommendation, if we see like the recent ones, 2021, they say like sacral neurectomy doesn't exist theoretically in the armamentarium. With neuroperviology, we have sometimes stimulation of some specific nerves. I've seen it twice during my fellowship, and I did it twice. One of the patients is fine, the other is not fine. So I quitted doing it. But we know that if we want to do it, as Dr. Guan said, it's for the midline pain and in the same time of removing the implant. So we cannot say like, okay, they have endometriosis, let's just remove the nerve and then keep endometriosis. So if you do a surgery on endometriosis, you remove all the implants, plus you do neurometectomy if the pain of the patient is in the midline. But with the new neuroperviology, which is now an increasing specialty in pelvic pain, we know that they can put some stimulators like the pacemakers for the heart or whatever, and then they can stimulate some types of nerves, even the plexus, and then they have better result than just to cut the nerve when it's going to alter the voiding for the blower, sexual problems, arousal problems, orgasm problems. So I told you I did it twice. One worked very well, the other no. But with the one that worked well, she's now in constipation, and then yeah, she has to bear the consequences of the side effects. So this is the problem with, and I'm not doing it anymore.
Yeah, so it has a lot of side effects potentially, and they're permanent, and it sounds like the results really vary, and it just sounds like the risk may not be worth it. Yeah. Neuropelviology is really interesting. So that's really cool that, one, you're able to speak to some of that, because I think it does have a lot of implications for pelvic pain and endometriosis and understanding how we approach this. So one question that we have is, if a person comes in with suspected endometriosis, are there situations where you might decide not to do surgery? And, what's the thinking about that? If this is somebody who's coming in saying, I'd like to have surgery, are there situations where you might recommend against it?
So I can give these comments. So for the patient coming to me, because I'm most patients referral based. So patient basic is coming for a pelvic pain. Obviously, I go in to do the surgery, right? I do believe incisional surgery help with patient a lot of pain and reduce pain and improve quality of life. However, if the patient just coming for endometriosis, if they, like example, if they come in here, they say, okay, I just possible have endometriosis, possible not endometriosis. So we do the pelvic exam, then find out it's not. So we have certain location more predict endometriosis. If not, then we possible said you should consider it. You need to do it. The only we talking about, I offer patient you're optional. I never said not do it. Why? Because until now, the gold standard of diagnosis of endometriosis is still laparoscopic surgery. It's considered surgery, even you put a scope in, right? Even one small incision is still surgery. So that's why you really want to find out, you know, you have endometriosis. Basic is only way is to do the diagnosis, because there's a 30% patient, no symptoms. So you no pain, you have endometriosis, some patient very severe. And that's why we give patient optional. Sometimes if I suspicious anything, I order MRI, because I call this kind of non-symptomatic patient called silent endometriosis. This is the worst nightmare couple patient I had. One patient so went to the ER. Maybe Tamisa was there for that surgery. So went to the ER. She had basically have a pyelonephrosis, have back pain. So she's a physician. She went there and they did a basic culture and then find out have pyelonephritis. So they ordered MRI, find out have kidney failure, have big nodule on her ureter. She never have symptoms. She had one kid, no problem with pregnancy, no problem with that. So she had a big endometriosis. This is not only one. We have patient bowel endometriosis, have everything. And one patient have a fibroid coming, another physician refers to me because she just a fibroid. And so patient just, because fibroid is huge, 16 or 17, I think, centimeter with the big uterus. So initially I said, okay, I do it, I'm going to do the surgery. So because patient come to my office, I always do the pelvic exam. So I put the finger in her rectum and find out there's a big nodule. I do the MRI. She never had bowel symptoms, never nothing. She just have little bit heavy bleeding because of fibroid. She had something mucosal fibroid. No one can suspicious she had a rectal nodule. So she had big rectal nodule. I send to MRI, we cancel the surgery, we get a colorectal surgeon, end up with bowel resection. So almost got the colostomy. So this is the kind of situation if you don't know the diagnosis, how you do it. So that's why I always do the complete history and physical exam. Anything suspicious, we do the exam. If we rule out all this severe disease, if you think about you don't need to diagnosis, don't need a surgery, you can option observation, because we want to find out if anything compromise ureter, bowel, and any vital organs first. I don't know answer the question, but this is difficult to answer because basically we give patient, I give patient choice, because if you really want to know, then no choice, we go into do the surgery. But if you think about, don't worry about, I can choose not to, then you choose not to. We just do some imaging or physical exam, rule out any kind of critical organ involved.
Right.
So how you guys deal with?
Well, and with the silent endometriosis, so there may be some lesions
Yes.
that a person has that don't necessarily cause any symptoms. And so, but it would still be really important to remove those.
Yes.
Yeah. Would y'all agree, Dr. Nassif and Dr. Koythong?
I agree. I have a very similar approach to my patients. I have an open discussion, you know, depending on our suspicion for endometriosis. Our physical exam really is limited by what structures we can reach. So who knows what higher structures could potentially be affected by endometriosis that we're missing on our pelvic exam. A lot of times I think the patients that come to us also have, you know, their year 5, 6 into their journey of their pelvic pain, and they've tried multiple other things by other providers and they've unfortunately failed, and an answer really is kind of needed in this situation. And also part of that evaluation should include evaluating for other pain syndromes that unfortunately are very common that happen concurrently in our patients with endometriosis in order to optimize their alleviation of their symptoms after surgery.
Yes, so I think that the difference between asymptomatic and silent endometriosis is a little bit subtle. Dr. Guan, I think that you meant by silence when you have like a compression on the ureters or a nodule on the bowel that is not still symptomatic because the creatinine is normal or the BUN is normal, or there is no like any bowel occlusion, but with time it might affect these organs, like they can come into a complete bowel occlusion or a silent kidney. So this is definitely, you can sometimes do the diagnosis on physical exam history not too much because they don't have symptom, ultrasound or MRI, but definitely, if you want to know the diagnosis and be sure it's endometriosis or not, you have to do diagnostic, at least diagnostic laparoscopy, if not an operative one, and robotic surgery to be able to get tissues and to be able to diagnose well what you have.
Great. Yeah, so having that diagnostic lab and using that as an opportunity to treat is really important. Yeah, a lot of patients will say, oh, well, I'm just going to go see my regular OB-GYN just for a diagnostic lab. And then, you know, if I need to go see a specialist, I'll do that. What are your thoughts on that diagnostic lab and having that initial surgery with an unskilled, somebody who doesn't have that expertise in working with people who have endometriosis?
So this is I think everyone have this, I think Tamisa and Dr. Nassif have the same feeling. I have so many patients coming in with, so my physician told me no pictures. So put a scope in, I have no endometriosis. So however, we put a scope in, endometriosis everywhere. That's why she still pain. So then a lot of physicians told patients, oh, this pain should be from your mind. So this is the reason why I think this is not enough education for this our part, because we not educate our physician well. Basically, if you do a diagnosis, there's a typical, right, endometriosis. We always talking about just joke. Even monkey can diagnose a typical one because you have powder burn, everyone can see it. But now, what's differentiate endometriosis specialists like our groups here, or they do everyday other stuff. They do so many things. Endometriosis, maybe they do 1 or 2 cases or 3 cases a year. They even not see. So what they doing? They going to put a scope in. They see the typical one. They say, wow, this is endo. You have endometriosis. But they see the blister. They see some of small lesions, other lesions like peritoneum windows, and some adhesions, some color change, right? So for us, this is kind of endometriosis. We've proven, obviously, this is not 100% endometriosis, but their percentage like range from 30 to 60%. Actually, I have a video on Facebook about this one. So basically, this will give you diagnosis. But if you go to the someone not expert, they put a scope, they in rush, they put the camera in, and they not use the right technique, they should put a scope very close to the lesion. So it's huge difference. You put a scope very close nearby, or you just close far away. Sometimes you see nothing. So when you put a camera very close, you see the lesion. So this is all huge difference. That's why I think this is kind of different from my opinions. A lot of they do a wonderful job in diagnosis, but some not. So,
I agree. I find that the role of diagnostic laparoscopy really depends on the experience of the gynecologist doing the diagnostic laparoscopy. And for me, I don't do a diagnostic laparoscopy. I do a diagnostic and operative laparoscopy, like Dr. Nassif said before. Even if there aren't any obvious endometriosis lesions, it's highly possible it's something that I can't appreciate with my eyes, and we need to take biopsies just to make sure there's not a pathologic diagnosis of endometriosis. So I'll never just do a diagnostic laparoscopy. And then kind of telling a story, at the beginning of my fellowship with my first few days in surgeries with Dr. Guan, I really hadn't had any experience with endometriosis as a resident. And I remember him doing a surgery on a patient when an excision of endometriosis. And I remember thinking in my head, what is he doing? What is he seeing? I have no idea what he's doing. Is it really endometriosis? And I've always followed up that pathology, and all of it came back endometriosis. So at that point in mind, I was like, obviously there's something more to the story that I need to understand. And that really is kind of the education, unfortunately, we have in our providers in residency and medical school is really subpar in recognizing the different appearances of endometriosis.
Mm-hmm. Yeah, I mean, the story that, Dr. Guan mentioned about, a patient being told that they don't have endo or they barely have any endo, and then they go see a specialist, and it's like it's everywhere. I mean, I've been that patient. I've been the patient who's been told, oh, I don't know why you're complaining. You barely have any disease, which we know as well. By the way, as a side note, staging does not correlate to your symptoms. But yeah, I've been told, you barely have any disease, and then gone to see a specialist, and they've been like, oh my God, I'm looking at your pictures and it's all over the place. So it's really important that doctors do have that training, that they do know all the various, appearances of the disease, not just that, cigarette burn, that red blister, those, stereotypical appearances, because I think that contributes so much to the diagnostic and treatment delays that patients experience when they are told, you don't have anything wrong with you because I didn't find anything, but I've only seen this a couple times. So, it's hard. It's really hard.
So if it's easy, sorry to interrupt you.
Mm-hmm.
So that's the reason we have this conference. So
yes.
That's why endometriosis is so difficult to diagnose, to treat. So that's why the 4 words this month, basics this March 27th is the endometriosis day. So this month for endometriosis month, but in China, this day is endometriosis day. They consider this day, advertise this day very, very aggressively.
Mm-hmm. And back to, sort of questions about like being told it's all in your head. We have a question from a participant who's asking about, having anxiety and endometriosis and, feeling that she's having like increasing anxiety. What do you think is your take on anxiety and endometriosis?
To me, they're very, very, very closely related. Anxiety, depression, PTSD. And I think it's a combination of being gaslighted by multiple healthcare providers over very long amounts of times, months, years, possibly decades, and being told, oh, you're a woman, it's normal to have this much pain during your period. You just need to take some ibuprofen and a heating blanket and you'll be okay. And I think more recently, there's evidence that endometriosis itself, with the hormonal changes, it kind of creates, actually induces some neurological changes as well that predisposes you to, unfortunately, anxiety. And then you get in this endless vicious cycle of anxiety from, the disease itself, the systemic response, and then being gaslighted by those healthcare providers.
Yeah.
Yeah, well, definitely. When you are in pain every day, you wake up with pain, you live with pain, you work with pain, you can't have intercourse because of pain, you can't take care of your kids because of pain. So it's totally normal to have anxiety, depression, and it's why patients with endometriosis, they need psychological counseling and sometimes psychiatric counseling because of the pain and the depression they can have. So definitely there's a strong relation. Endo can lead to these symptoms, but also the opposite is not always true. So it's why we can't label this is in your head before we're like having a diagnosis for these patients.
So another one is I need to mention here, I hope here have family in the future, maybe in this discussion, I think have family with you guys. I really appreciate some of family support. This is very common. You have pain with depression, anxiety, and PTSD, as Dr. Nassif mentioned. But there's one of a great support from the family member and from sister, from husband, from mom, and first understand and recognize this is a disease. This is a problematic disease. This is a disease very difficult to treat and can recurrent. This disease can cause a lot of problem. Basically, you cannot walk. Most people, right? You cannot go to work. You cannot taking care of kids, and this is a lot of anxiety. Then family support is very critical to taking care of patient with endometriosis and pelvic pain. So that's why we include all this together. Not only the surgeon doing the surgery, medical treatment, and pelvic floor physical therapies, other specialties, and that is one very, very huge important things from your family support.
Yeah, it's really important to have support from your family, from your community. And I think that that's part of the reason why we created the Endometriosis Foundation of Houston and the Houston Area Endometriosis Group. Because a lot of us felt isolated. We felt like we didn't necessarily have that support or the people that we could relate to with the disease. And I think it's so important to recognize that this is a traumatic disease. If you're feeling anxious or depressed when you have endometriosis or you're feeling traumatized, you are not alone. That's something that so many of us experience. And it doesn't mean you're crazy. It doesn't mean it's in your head. It's a really normal response to something really, really awful in your life. And it's okay to feel those things, and it's okay to get help for those feelings as well, if you can. We had a question about what about recurrent disease after expert excision surgery? People who come back years later with true recurrence, not just disease that's left behind, but disease that's actually come back. What is the risk around that? Is that something that happens? Is that something that's more rare? Because we talk about excision as a means of like cutting out and getting rid of the disease. How do we manage expectations around that? I know that was a really big question.
So recurrence can definitely occur even with expert excisional surgery. To me, it kind of plays into the origin of endometriosis, why it forms in the first place. Stem cells and possible embryologic origin. When you go and do excision surgery the first time around, you can still have any potential stem cells that develop later after that and form recurrent disease. Now, I don't think it happens in the vast majority of patients. Dr. Guan quotes, 30% in a patient who keeps all of their pelvic organs, but 30% is still 30%. And it's still unfortunately quite high. I like to think of endometriosis as a chronic disease, that of which surgery really is only one component. And some patients unfortunately do require more than one surgery, but the hope is that she, can have many, many years pain-free or symptom-free. And that's all we can really hope for, at least with the information that we have currently.
So that's really interesting, talking about the embryonic origins of the disease and potentially the stem cells that maybe haven't fully expressed themselves. Is that sort of, we kind of hear people talking about microscopic disease in this debate of like, is there microscopic disease? Is that a thing that exists? Or should you be able to visualize all disease?
I think microscopic disease can happen, definitely, 100% for sure. You know, the easy disease to recognize is the one that's obvious during laparoscopy. And that's why, again, I always do an operative laparoscopy rather than a diagnostic laparoscopy, because I know that my eyes are not going to be better than a microscope. So I will always take biopsies.
Yes, definitely agree with Tamisha. The microscopic disease exists. There's especially a new publication from Connex from Belgium, where they found, especially in the pockets, like the Master Allen's pockets that we find in the ovarian fossa next to the uterosacral, that even if like microscopically we don't see it, excising these pockets can first get microscopic disease when we saw. So they will come always positive. I had like at least 3-4 patients here in Houston where they have these pockets, we remove them, and then they're now symptoms free. And even if I didn't see them even with a scope that was magnifying, these pockets came positive with endometriosis. It's the tissue, and this was published clearly by Connex. And definitely also the other way is when we do some biopsies and then the biopsy is negative, so it doesn't always rule out endometriosis, because we can find it another place which is microscopic. So even if we do laparoscopy, we biopsy some lesions and it comes back negative, and the patients have the typical symptoms of cyclical, non-cyclical pain, pelvic pain, we have to take care that you don't have endometriosis for sure, because we know clearly from recommendations and from publications that a negative biopsy cannot rule out 100% this disease also. So this is the dilemma that we have recently.
Right. Well, and I think that also, it depends on, a lot of times when you're taking biopsies, you might be taking a sample that has wider margins. And I think it's important to remember that you don't necessarily control what piece that the pathologist samples out of that. So, and I think that a lot of patients get really disappointed when they're like, well, the biopsies came back negative, so that, now I don't have answers to my questions. But yeah, I think that's an important discussion to have with your surgeon, and what your surgeon's thoughts are about that negative biopsy. And is this really, a case where you don't have endo, or is it a case where, pathology isn't always 100% accurate?
Yeah, and about this negative result, right? So from pathology, sometimes you remember we do the surgery. If you have endometriosis very, very tiny, so we grab it. So potential, we already grab off the endometriosis. Another ones, we use the laser, use the cautery to cut the endometriosis. The thermal can destroy the endometriosis. Obviously, if you have endometriosis everywhere, maybe not affect. But endometriosis somewhere very small. Sometimes during the surgery, we see that we cut endometriosis disappear. So that's why this is pathology. We just tell patients, we always tell, we should treat the symptom, not treat the disease. If really we do the diagnosis, right? You remember before, if ablation surgeon, let's talk about ablation surgeon. So I put a scope in, I do the ablation. How we tell you have endometriosis or not? Based on what I see, right? So that's why I said, I always tell patients, if pathology is negative, but her symptom is gone, I'm pretty sure. I said, I took the picture there and did not find it. Maybe because we handle the specimen, it's already dropped somewhere in the specimen jar, right? Not in the specimen layer. So that's why pathology did not see it. So all we do, we have to use energy to cut. So maybe we already destroyed the endometriosis. This need to be considered. So if that point, I pull out a picture, I say, oh, this is definitely endometriosis, but then not report. Ignore it, you still have endometriosis, your pain is fine, it's good. So you just keep your mind, this is the reason.
Right. Yeah, and there are other things that cause pain aside from endometriosis. And I think the most important piece is that whatever it is was removed and you feel better. Like ultimately, whatever the problem was, it was treated, you've improved, and hopefully you can get your life back. We are out of time, but I just wanted to do one more question because we haven't talked at all about menopause today. So we have a question. She says, I'd like to ask how patients post-excision surgery, post-hysterectomy, and post-bilateral oophorectomy may treat their menopause symptoms without stimulating additional endometriosis growth. And also, do they recommend any particular doctors? Let me see. Do you recommend any particular OB-GYNs for regular care after everything has been removed?
But we know very well that endometriosis can still be active and symptomatic after menopause. We know it. It's not in the majority of cases, but in the small part of the cases. And in general, this will be a surgical treatment. So here we have to go more for surgery because we don't want to use a lot of hormones. And we are uncertain, especially of the risk of malignancy in the postmenopause. So why these lesions are still symptomatic. In the postmenopause, if we want to use any like medical treatment, we always like prefer to go for aromatase inhibitors like letrozole or whatever. So these will decrease the formation of estrogen in the peripheral tissues like the fat or whatever. And if we want to like use HRT, so postmenopausal hormone replacement therapy, and the patient had previous excision of endometriosis, we can do it because it's not a contraindication. So this is what we know for endometriosis and menopause in general. So patients can see their own doctor if they want. They can see specialists in postmenopausal. We have in TCH and Baylor also some of our colleagues. They just take care of the menopausal patient. For example, we have Dr. Ali, Nishat Ali with us in Baylor. So we can always also negotiate, discuss with them if we need any like additional opinion from the menopause specialist. They are gynecologists, but some of them just deal with menopause. Tamisha, Dr. Guan?
Yeah. I agree. I think hormone replacement therapy. I mean, if you're pursuing hormone replacement therapy, obviously you're having symptoms that affect your quality of life. And I think really the recommendation should be for the lowest dose for the shortest amount of time possible to help you with your symptoms. And Dr. Nassif is correct. So we do have a menopause center here at Baylor, of which Dr. Mina Nishathali, ALI, heads that center.
Yes, so about menopause, right? So I'm personal experienced because so many years. So I normally talk to patients, if I remove your ovary, remove uterus, you're going to be endometriosis kind of recurrent rates decrease and more chance to be cured. However, so we prefer not give any estrogen at the beginning of, I normally ask patients, I said you possibly end up with the try other medications like kind of antidepressant, FDA approved to taking care of your hot flash and menopause symptoms for almost 1 year. This is no evidence base. It's off label. So I just personally thinking about it because even you remove all the disease, we still consider a micro disease. So if this micro disease still active because you just remove ovary and uterus, potential can produce the potential. If you give the estrogen right away, you can promote, can make the endometriosis growing back and faster. So I want this disease to die out. So I think about how long we give. So I normally tell patients, if you can give me time, at least give 1 year. So I use all kind of basically it's the medical treatment, non-hormonal medical treatment to control your menopause symptoms. Transition to after 1 year, you still there. As Tamisa now, we're kicking with the lowest doses. Start with lowest doses, and then you can control your menopause. If cannot, symptom we increase a little bit. So this is kind of end up with because we have patient. She have 12 years pelvic pain because she had the varicosis in her belly. She from Dallas, so I still remember. She came to me and no one wanted to do a surgery. And because no one wanted to do a surgery, I did a surgery. So she wanted me to remove everything. Her husband is a physician. She told me, her husband said, Dr. Guan, I guarantee you she's not going to take any estrogens. However, after 6 months, she went to over-account. She took over-account estrogen. And after 6 months, then now it's 1 year now. So she came back with the pain and came to me. I did a surgery again, endometriosis. So this, not only this patient, couple patients, this kind of situation, also use estrogen coming back. And obviously a lot of patients related to high dose estrogen. That's why give me the kind of label. I try to manage all this kind of patient. In the meantime, I try to not remove ovary. So I told patients that you keep your ovary, not go to menopause, and always you have higher chance to have another surgery. But compared to you menopause symptom, you just transition from one symptom to another symptom. Right. Why not you give it your time for free for a couple of years, then you need to do another surgery, right? And that way you have a symptom from this one. No transition time, you get to another symptom. So that's my suggestion.
Right. Yeah, it's a hard decision trying to decide if you leave that ovary and take the risk of maybe needing another surgery later on, especially if you're prone to endometriomas. Do you, go with the HRT? Can you wait it out? It's lots of questions to discuss with your doctor. And it's great that Baylor has that menopause center. I wasn't aware of that. So that's a great resource for a lot of the people in our community. Thank you all so much. I know we're going a little over time and I want to be really respectful of your time. We appreciate you joining the Endometriosis Foundation of Houston today in our community to help us learn more about this disease. As always, Dr. Guan, it's a pleasure. Dr. Nassif, Dr. Koythong, thank you so much for joining us. It's been great learning more about you two and your approaches to endometriosis because, we recognize that you are new to the Houston area. And I know that our community has been really curious about your approach and how you manage the disease as well. Thank you to everyone who joined us today. We received so many questions. I know that we didn't get to them all. I'll try to follow up with the doctors maybe. I know Dr. Koythong, you were going to do a Q&A for us. And we're looking forward to that. So thank you again, everyone, for joining us today to talk about endometriosis. It's been a pleasure, and we will have a recording of this up later in the week for those who missed it or anyone who wants to watch it again. Right.
And thank you again for Endometriosis Foundation of Houston, all leadership and all members and supporters. As we said, just Alison mentioned, we have a menopause center, we have IEI. We almost, if you have anything need in OBGYN, we have it. So we have a psychiatry department. We have global, even you want to do something in the outside another country, we have global health. We have every single specialty you have. And we have a great faculties, experts. We not advertise for Baylor. We don't need to advertise. We Baylor is pretty good, right? So just let you know, we have all you need, and we have a physical therapist for the pelvic pain. So I just don't know what we're thinking about. Just advertise a little bit. If you need a resource, you can ask Tamisa and Dr. Nassif or myself. You see GS, you want to see something else, we can refer you to. So we have all kinds of specialty here.
Right. Great. So, and it's great to have all those resources available under one roof. Great. All right. Well, thank you all so much. And I hope you enjoy the rest of Endometriosis Awareness Month. And I hope that it is flare-free for all of you. Take care.
Take care. Bye.
Thank you. Bye-bye.
Thank you.